Hello, I'm Dr. Gundipe. I'm the pediatric advisor for MSF Belgium, and I'm presenting poster 124, Mise en œuvre de l'algorithme de décision de traitement de la tuberculose en contexte de forte insécurité alimentaire, Leçons de Madarounfa, Niger. So this project in Niger has recognized that they have a large inpatient therapeutic feeding center where they treat a lot of malnourished children. And TB is one of those diagnoses that is very important in this population because it is more prevalent among this group because weight loss is a significant sign of tuberculosis. So in this project, they began using the WHO treatment decision algorithms that were made in 2022 and tried to apply them to screening of patients with suspected TB in their ITFC, Therapeutic Feeding Center. They began to do this in June of 2023. And with the help of a research study through Tactic. And the initial ambition was, with this, to screen every patient that came into the ITFC for TB using these algorithms. But they realized soon that this was not going to be sustainable if they were to come into the nutrition peak where they would have triple or quadruple the number of patients that they normally have. They wanted then to figure out a way to adapt the screening with this algorithm to meet their needs operationally, rather than just seeing the first come, first served of the patients. So what adaptations did they make when they moved from systematic screening to what they would do in peak? The first adaptation that they made was that they decided to classify patients as those who have high suspicion and screen those rather than screen everybody. How did they decide which patients had high suspicion for TB? These are the patients who had malnutrition, which is the majority of the patients, which was all of the patients, but also with cough of 2 weeks and fever of 2 weeks. If there was a suspicion of them having a TB contact, or if they were not responding to nutritional therapies. They also, during this period, had to control the use of radiology and X-ray because they weren't able to X-ray everybody. So they limited the use for patients who were malnourished, who had signs of severe pneumonia, who are not responding to treatment, rather than everybody who had a lung finding. And they also had patients who, if they had any signs of bone problems, they put them also as high risk or prioritize them for getting an X-ray. If they also had signs of pleural effusion, and if they had a very clear sign of a contact with TB, they included them for radiography or X-ray. The rest of them, they deprioritized in the peak period. So they had an updated screening algorithm that is shown here that they used that was matching, that had the treatment decision algorithm embedded in there, but wasn't screening 100% of the patients, only the ones with high suspicion or who were failing therapy. So what were the lessons that they learned from making these updates? While the TDAs, the treatment decision algorithms, are useful, we have to be realistic in applying them, especially in places where there's nutritional insecurity and malnutrition peaks. So you need to think of adaptations with your team in these areas to make sure that you're able to screen the patients who will need it the most and support your team to make that decision together. Whatever happens, there will always be an increase if you use the treatment decision algorithms in screening and finding cases of patients with TB. And you should expect that this will be the case whenever you use these treatment decision algorithms. Thank you.